beta kappa. And then she went to medical school at WashU. And fortunately for us, she came back to Birmingham to do residency in internal medicine, followed by a year of chief resident and 3 years of fellowship. I had the pleasure of meeting her when she was chief resident, exactly 6 years ago, when she had a very complicated patient in the SICU. And when we talked about the patient, I was like, who is this resident? I had never met her before. I said, she's amazing. And that's the same thing I've said all these years. When I mentioned her to my husband, he's like, I know, Jori, she's the one you always say great things about. I said, yeah. So Jori, I would like, you know how I don't follow the rules for the introductions? What I would like to say to the audience today, especially the young people, there are a lot of young people in the audience, is to see how Jori was able to take a problem, a gap, which is, maybe you don't know, but there was a huge gap in how we took care of patients with this disease that can be life-threatening, called heparin-induced thrombocytopenia. I had been trying to do something about it, but I was never, ever any close to as efficient and effective as she's been. So all of us encounter situations in our own specialties where we realize something needs to be done, and we do something about it. Jori has only been in the faculty for less than 3 years. She's already well known at the national scene in this new way of thinking of hematology as systems-based hematology that she will talk to you about. The American Society of Hematology is one of the largest medical societies, very influential, very well run. And Jori has been a leader in that, in how someone from one institution like ours can start developing things that can be used in other places, but most of all, take care of the patients that we see every day. So it's very exciting that she accepted our invitation to speak to you. And even though we're pathologists in most of us, there are always things we can do in the footsteps that Jori is going to walk us through. Thank you, Jori.
So Dr. Marquez gave me an overly kind introduction, as she always does, but she is very much responsible for my interest in hematology and has really helped me develop an appreciation for coagulation, and everything that she does so beautifully is really part of the reason that I'm here. Yes. Oh, too many microphones. Okay. Great, thank you. So I really appreciate the opportunity to talk with you guys today. Excited to share some of the work that's very much been a team effort to rethink how we're able to diagnose and manage patients with HIT at UAB. Here we go, and I don't have any relevant disclosures today. So our objectives are going to be to define this field of systems-based hematology that Dr. Mark has referenced, including the objectives and scope of the field. We're going to discuss novel care delivery strategies to improve the diagnosis and management of heparin-induced thrombocytopenia, or HIT. And then we're going to talk about selecting appropriate testing for and treatment of heparin-induced thrombocytopenia. So here's an outline. I'm going to talk with start with some general discussion of benign hematology, really focusing on this new area of systems-based hematology. We're going to talk briefly about HIT, the pathophysiology, which is really the foundation for how we diagnose and manage these patients. I think it's a disorder that overlaps nicely between hematology and pathology, and certainly a credit to the fact that in order to do a lot of the things that we've done here, we've worked very closely with Dr. Sinyard and Laura and the COAG lab, and so there's a lot of overlap here. I'm going to talk about what we created at UAB, which is our HIT e-consult service, and then some new work that we're doing looking at how we diagnose HIT using a new assay called the P-selective expression assay. So just a little bit of background about benign hematology, and there's actually a lot of debate about what we call ourselves. Some people feel like benign isn't fair because what we're dealing with isn't truly benign. So some people call us non-malignant, but then people don't like to be non-something, and so now everybody's calling it classical. I don't know what I'm supposed to call myself at this point, but either way, the issue is that there's really a shortage of benign hematologists. And so this has been well documented in the literature that unfortunately the supply of trained hematologists is falling short of increasing clinical demand. Of our, we have a combined training program in hematology and oncology that's pretty consistent across the nation. Only 4% of our trainees in 2018 to 2020 indicated that they were actually interested in benign hematology, which is just tragic in my opinion. The number of investigators too, so the science happening in the field has really declined dramatically. And so at the same time, there's a lot going on in the field. So there's significant advances looking at new therapeutic agents, and also a lot of work that's being done in creating new guidelines and standards for practice. And so with this background, so our large professional society that Dr. Mark has mentioned is the American Society of Hematology. And they actually hired a consulting firm to come in and say, what's going on in benign hematology? And what is the role of the hematologist in the changing United States healthcare system? And so this was published in 2015, and this is a quote taken from that article, that ASH sought opportunities for hematologists to optimally contribute in the emerging 21st century health ecosystem through a novel and sustainable role, and this is the systems-based clinical hematologist. And so what is systems-based hematology? This is the kind of how I see myself. This is the work that I try to do every day, is this is a field that's dedicated to the development of pathways that deliver care that is high quality, cost-effective, evidence-based to patients with blood disorders across health systems. So the field is really based on the foundation that a lot of what we do in benign hematology falls outside of the realm of our division. So much hematology happens in surgical patients, in medical patients that don't necessarily see a hematologist. And so how can I, as a hematologist, partner with the health system, partner with providers across the health system to make sure that we are consistently providing excellent care related to anticoagulation, management of anemia, all sorts of things that fall under that benign hematology umbrella. And so this publication initially came out in 2015. We published a follow-up publication in 2020 that actually looked at, what are people doing that falls in this category of systems-based hematology? And so what we found, and I've listed some examples here, was that there's kind of two ways to approach it. The first is targeted initiatives. So there's a hematologic problem that would benefit from targeted intervention. And some examples here, we're going to talk about HIT today, but things that you're familiar with as laboratory, so hypercoagulable testing. Testing for hypercoag disorders is often overused. So can we target some sort of initiative in order to decrease that? The use of inferior vena cava filters is another one. And then disorder-specific care pathways. The example I often use is patients that have pulmonary embolism that may not be acutely ill can often be managed as outpatients rather than being hospitalized, and creating a specific care pathway for optimal management of a specific disorder. At the same time, there's also within systems-based hematology more comprehensive initiatives. So things that are looking across diagnoses to really think about how we can deliver care universally in a better way. So blood product utilization is something that may often fall under pathology, but is often in different health systems may fall more under hematology. And so it's certainly something that is cross health system. Anticoagulation stewardship is a newer idea of looking at how we're using anticoagulation safely and consistently across health systems. And then incorporating novel care delivery strategies like electronic consultation falls under this umbrella as well. So this is just to kind of give you a general idea of what systems-based hematology is, what that work looks like. But today we're going to be focusing on a specific example of targeted initiatives, looking at how we can improve the care of patients with HIT within a given health system. And so with that, let's jump into what HIT is. And there are some people in this audience that may be extremely familiar with this diagnosis, or there may be some people who are not. So I'm going to try and strike that balance and do a brief overview of what HIT is. So this is an immune-mediated adverse response to heparin that results in thrombocytopenia and potentially catastrophic thrombosis. And so I've included some illustrations, which we're currently working in our group on publishing a kind of visual description of what HIT is, because it's a little bit of a complex diagnosis to wrap your head around. But when I think about HIT in the pathophysiology, there's basically kind of a four-step key player process. The first is heparin. The heparin molecule itself is really important here, whether it's unfractionated heparin or low molecular weight heparin, right? This medication is a negatively charged polysaccharide that has anticoagulant activity. We then have PF4. So platelet factor 4 is a positively charged chemokine that's released from alpha granules from activated platelets. What can happen is actually the formation of these multimolecular complexes, including PF4 and heparin. And it's thought that really this electrostatic interaction is really important for the development of this complex, which ultimately is immunogenic in some people. We don't know why, but basically leads to immune cell recognition and the creation of these anti-PF4 heparin antibodies. So how does that get us to thrombosis? So what we know about these anti-PF4 heparin antibodies is they have the ability to activate platelets. And so you can see here that this is the multimolecular complex we talked about of heparin PF4. This is the antibody that's created. This binds to the Fc receptor on the surface of the platelet, leads to increasing PF4 release, so continues to feed that cycle in a process of activation and consumption. So patients actually become thrombocytopenic, their platelet count goes down, but it also feeds this pathway for the development of thrombosis. What's important is we often think of HIT as a platelet disorder, but we know that the thrombotic risk actually arises from the interaction of that anti-PF4 heparin antibody with other cells as well. So you can see here some examples of binding the Fc receptor of a monocyte, leads to tissue factor expression, the release of tissue factor containing microparticles that then facilitate thrombin generation. We see activation of neutrophils with the release of nets, as well as which can include more PF4 von Willebrand factor as it interacts with red cells. And then we often see some sort of concurrent cause of endothelial injury. So this is in a surgically ill patient or a medically ill patient. We also know that complement activation can occur that can then cause endothelial injury, again leading to tissue factor expression and thrombin generation, as well as the release of von Willebrand factor, which continues to feed this process of platelet activation and consumption, and ultimately the development of catastrophic thrombosis. So what does that actually look like in kind of an epidemiologic perspective and in the clinical perspective? So the incidence of HIT is reported to be about 1 in every 1,500 hospitalizations in the United States. So it's rare, but in a lot like ours, if you're seeing enough patients, it's not that rare, is how I often think about it. There are certain things that we know increase or decrease the risk of developing HIT. So we see an increased incidence in patients having major surgery, particularly cardiac or orthopedic surgery. We see an increased incidence with the use of unfractionated heparin, so that larger molecule rather than low molecular weight heparin. And we do know that shorter durations of exposure, specifically if exposure is less than 5 days, actually decreases the risk of developing HIT. So patients with longer exposure are at higher risk. So what are the clinical manifestations that we see? Thrombosis is the biggest concern. So it's estimated that about 30% of patients develop thrombosis. There's some single institution reports, and I include those statistics here. So the question is, arterial or venous thrombosis. You see both, but it ranges. Some reports say that it's a 1-to-1 ratio, that basically you're equally as likely to develop arterial as venous. Some say 1-to-4, where you're more likely to develop venous to arterial. So there's a wide range of severity of what that thrombotic event looks like. These patients will also have a decent bleeding risk. That's likely because we're having to use high-risk anticoagulants in this patient population. The thrombocytopenia itself is not usually thought to be the cause of bleeding. There was an interesting study that actually compared hospital discharges in patients with HIT and without HIT. And we saw from that in patients with HIT compared to those without, an odd ratio of 5.1 increase in the need for amputation. So that's seen based on single institution reports around 3 to 8% of patients. A significant increase in odds ratio of mortality of 4.1. And the quoted mortality rate ranges anywhere from 6 to 50% in patients with HIT. And really an increased length of stay as well, a greater than 3-fold increase of length of stay. So a lot of clinically relevant outcomes here for these patients who do experience HIT. So the challenge with HIT often is the diagnostic process. So there's nothing straightforward, unfortunately, about determining if a patient has HIT. And so I'm going to take you through this diagnostic algorithm because I think it's important to understand this framework to think about how we ultimately design an intervention in order to help it go more smoothly. So in patients with suspected HIT, the first thing that's recommended, and this is consistently recommended in guidelines, is to calculate something called the 4T score. The 4T score is basically a scoring system that assesses the likelihood of a patient having HIT. It's actually it has demonstrated fantastic performance. It has an excellent negative predictive value. So basically a score of less than 3 or less than or equal to 3 has a negative predictive value of almost 1, which is almost better than the laboratory assays themselves that we use. And so that's why you see here in a patient that has had an accurately calculated 4T score, it's less than or equal to 3. Basically, we proceed down to the bottom to say HIT is unlikely. And so no additional laboratory testing is recommended. The patient should continue heparin, and there's no need for any use of a non-heparin anticoagulant. However, the positive predictive value of the 4T score is not great. So what we know is that if a patient has a higher score that's intermediate or high risk, we then have to proceed to the next step. In this intermediate period, the recommendation is that we stop heparin because the concern is that more heparin exposure in a patient with true HIT can worsen the process. And we start some form of non-heparin anticoagulation. So an anticoagulant to help prevent the thrombotic complications that happen because of HIT. The first screening test that we do is an enzyme-linked immunosorbent assay. At least that's what we do here at UAB. There's a bunch of different types of immunoassays, but this is what we use. And I'll do all of this with the caveat that I'm a hematologist talking to a room full of laboratorians about laboratory assays. So please bear with me in my understanding of these assays. So the way that this basically works is that the cell, the plate is coated with either the heparin PF4 complex itself or a very similar polyanion, and patient serum is then added in order to hopefully identify if they are present, those anti-PF4 heparin antibodies. A substrate is then added in addition to an anti-human antibody. We see here a change in color based on the concentration of the anti-PF4 heparin antibody. So a higher optical density suggests a higher concentration of antibody, and studies have demonstrated that a higher optical density is associated with a higher risk of HIT. The important thing here is that this test is overly sensitive, or not necessarily overly sensitive, but is often detects antibodies that are not clinically significant, likely in part because this is detecting IgG, IgA, and IgM, when we think actually the IgG antibody is what's pathologic. But this is really just an initial screening tool. That screening comes back negative. We feel comfortable saying that HIT is unlikely and no laboratory test is needed. Having trouble hearing me? Am I cutting in and out? Yeah. Switch. Well, I'll keep going and we'll, if it keeps, hold on. I'll use this one. Why don't we do that? Is that better? No, not better.
The other, the one you have is probably better.
Probably better. Okay. Maybe. Okay. Green line's on. Yeah, well, I took that one back off. All right, we'll power through. Sorry to the people on Zoom if you're getting any gaps. But so yeah, so if the EIA is negative, we've ruled out HIT. However, if it's positive, we need a second test. So basically what we have to demonstrate is that those antibodies that we found have the ability to activate platelets, right? That they have the ability to initiate that pathophysiologic process that we looked at, bind to the Fc receptor and cause platelet activation. The gold standard assay for this has been the serotonin release assay, or the SRA. This is a complex assay. It has a lot of requirements that make it very difficult to use, and is something that exists only as a send-out lab that many facilities are unable to run it themselves. So it requires platelets from specific donors due to kind of variable reactivity to HIT antibodies. And basically what happens is that here we have patient serum that's mixed with donor platelets that have been radio-labeled, have radio-labeled serotonin inside the granules. And so what we do is we actually see the exposure to 2 doses of heparin within those mixes. So patients' serum is exposed to a therapeutic dose of heparin or a high dose of heparin. What we expect to see in a patient with a positive result is that with a therapeutic dose of heparin, they're able to form that heparin PF4 complex that then binds to the antibody that's present, binds to the platelet surface, leads to platelet activation, and therefore the release of the radioactive serotonin that can then be detected, as you can see here. On the other hand, in patients that are the patient serum that's exposed to high doses of heparin, it actually disrupts the formation of that multimolecular complex that's needed for antibody binding. So that does not occur, no platelet activation occurs, so you actually see inhibition or no serotonin release. And so this is kind of the classic presentation or way to identify if a patient truly has HIT. But again, the challenge for this assay is that it's a send-out lab. It takes, we currently send to Diversity, it takes about 5 days to come back, requires radioactivity, can be difficult to use. But ultimately, that is how we, the gold standard for diagnosis. And people that have a positive result, you proceed with management of acute HIT. And those that are negative, it is unlikely. With the caveat being, there's a dotted line here, there is the potential for an SRA negative HIT, So ultimately, this is a clinical diagnosis. And so we have to be very careful about how we interpret those results. So this is a complicated process, right? There are a lot of barriers to optimal management here. First, it's identifying patients for testing, right? So calculation of that 4T score, who actually needs to be tested. The second is interpretation of test results. As we mentioned, there's a lot of potential for error here, and there's a lot of nuance to interpretation. And then ultimately anticoagulation selection. So we talk about multiple points here where there's decisions that need to be made on, does the patient need heparin? Does the patient need an alternative agent? And how do you determine if you need to make that switch? So we'll talk about now what we've done at UAB in order to try and optimize this diagnostic and management pathway with the creation of our HIT consult service. So this is all in the background of the publication of the American Society of Hematology guidelines on heparin-induced thrombocytopenia. So this came out in 2018 and is really the first comprehensive guideline document that's existed in this space. There's been intermittently some guidelines from groups, but this guideline document covered basically all corners of HIT care. And I've outlined here, basically they were divided into two categories. What I would consider to be phase-specific recommendations, so based on the diagnostic or management phase of HIT, and those that are situation-specific. So in the phase-specific recommendations, basically there's 2 recommendations for patients that are asymptomatic, how to screen patients, 12 recommendations for diagnosis and management of suspected HIT, 10 recommendations for the management of acute HIT, and 2 for how we treat VTE or use prophylaxis in patients with a remote history of HIT. There are also these situation-specific guidelines, so 3 that are specific to cardiovascular surgery, 2 specific to PCI, 2 specific to renal replacement, and then 2 regarding emergency identification. And so with the publication of this guideline, it really created an opportunity for us to ask ourselves internally, are we following the guidelines? And this is really the foundation of systems-based hematology work, is that as we are finding that there are standards for best practice, how can we look and make sure that we're actually achieving and following those guidelines to best serve patients? And so you can see here, I've listed the ASH recommendation, and then in our evaluation, what we found to be the current state. So recommendation 2.2 says that patients with suspected HIT, a low probability 4T score, the ASH guideline panel recommends against HIT laboratory testing. And I think any of you who've rotated through our laboratory medicine rotation or work with this or are familiar with this work know that frequent testing without consideration of the 4T score is quite common. And this is something that's seen not only at UAB, but that is seen across institutions, that we often see over-testing for HIT. We actually did an internal evaluation looking at retrospectively at the testing practices here at UAB. We used to have a platelet count alert. So basically providers would get a notification if the platelet count during hospitalization fell by 50% or more. We presented this work at the American Society of Pathology meeting. And what you can see here, and remember, a patient with a low probability 4T score really should not be tested. A patient with an intermediate or high probability 4T score should be tested. And so you can see here on the y-axis, we have the absolute number of patients, and then we're grouped by patients with a low probability, intermediate probability, and high probability 4T score. And you can see light green means that they had testing ordered, dark green means they did not. And in red, I've highlighted the bars that are discordant with guideline-based practice. So you can see here patients that had a low probability 4T score that did have testing ordered. At the same time, we had patients with an intermediate and high probability 4T score that did not have testing ordered. So unfortunately, we did observe this variation from best practice. 2 additional recommendations that we looked at as well was recommendation 2.3. In patients with suspected HIT and a low probability 4T score, the ASH guideline panel recommends against empiric treatment for HIT. And what we saw is that our providers were frequently using non-heparin anticoagulation, particularly bivalirudin, in patients with a low 4T score, and that this was often continued even after HIT testing returned negative. Recommendation 3.9 looked at in patients with subacute HIT A, so with acute HIT, the ASH guidelines panel suggests treatment with a direct oral anticoagulant rather than a vitamin K antagonist. So this is a really interesting development that for a long time we felt like warfarin was really the only thing that we could use to treat HIT. But we have new data that suggests that they can safely be treated with anticoagulants that are much easier to use, which is apixaban and rivaroxaban. But what we saw at our institution is that we were really still consistently using warfarin rather than these newer agents. And also, we observed in patients that had HIT, only 50% of them were actually seen by hematology during hospitalization. So many providers were managing this on their own, but potentially an opportunity for standardization here and involvement of our team, given this is our area of focus and expertise. So it's nice to talk about kind of generalities, but I think putting it in the context of a case is always really helpful. So these are two cases that happened before our e-consult service. And at the end, we'll come back and look at them and see how they might have gone differently with our implementation. So this is a 60-year-old female who was admitted with pneumonia. She got started on prophylactic anticoagulation with enoxaparin, 40 milligrams daily on her admission. She developed thrombocytopenia on hospital day 2. She did not have a 4T score calculated, and she did have testing sent with an initial screening EIA. On day 3, that EIA returned positive. The optical density was 0.547. And those who are familiar know that that's an extremely low optical density and is very inconsistent with the diagnosis of HIT. However, because of that positive result, she was started on bivalirudin, which is that non-heparin anticoagulant, which from a clinical perspective is much more difficult to manage as an IV infusion that requires frequent dose titration. And unfortunately, on hospital day 6, she developed a GI bleeding event. The following day, her SRA returned negative, confirming that she did not, in fact, have HIT. Another case was a 74-year-old male who was admitted for coronary artery bypass grafting, and you see that happens here at the beginning of the timeline. On hospital day 5, he developed thrombocytopenia, had a 4T score of 5, was appropriately tested with an intermediate risk 4T score, and was appropriately started on bivalirudin. Not surprisingly, the EIA returned positive with an extremely high optical density of 2.953, which was very concerning for true HIT. The SRA ultimately returned positive, confirming the diagnosis. And on hospital day 10, the patient was medically stable for oral anticoagulation. So it was started on warfarin. But when you start warfarin in a patient with HIT, they require bridging until that warfarin level achieves a therapeutic INR. And so that took 6 days. So the patient remained hospitalized for a bivalirudin drip, for bridging to warfarin, for a total of 6 days before that patient was discharged. So keeping these things in mind, the guidelines in the patient care, we ultimately decided to develop an intervention in order to try and make some improvements. So we had to think about the limitations of our team. And I think that's an important concept whenever you're thinking about how to make a change within an institution. What do you have the bandwidth to actually do? And so the ideal situation was that we would look at every screening enzyme immunosorbent assay that came through, but we didn't want inappropriate testing. But we looked at the numbers for that, and over 600 of those are ordered at UAB per year. And based on the limited capacity of our team, we just really didn't feel like we had the bandwidth to review all of those in real time. What we did find was that those that had a positive result was 100 per year. And so that felt like a more manageable number, and particularly might be that really high-risk patient population group that had an initial positive screening test for HIT. And maybe we could focus on that group first. That was kind of a reasonable scope for us. We sought to engage stakeholders, people who were involved in the process of diagnosing and treating HIT and might be involved in this process. So that included pharmacy, of course, working very closely with our coagulation laboratory, as well as clinical services that were frequently testing for HIT, and that includes CV surgery, ICU services, and the hospitalist service. And we looked at defining 3 desired outcomes. So the 3 things we sought to do were to, number 1, decrease unnecessary bivalirudin use. As I've alluded to, it's a tough anticoagulant to use. It's monitored with a PTT, which is not completely reliable. It actually requires manual dose calculations by nursing staff, which leads it to, makes it prone to medication error, and is reported to have a higher bleeding risk than heparin products. So lots of reasons to try and avoid bivalirudin unless we absolutely have to use it. We sought to increase the use of direct oral anticoagulants in our patients that were diagnosed with HIT rather than using warfarin. And we thought that with the use of direct oral anticoagulants, maybe we would even be able to influence this increased length of stay that was seen in patients with HIT, which, as we know, in our currently very full hospital, that's really a priority for the institution. So along with developing this plan, we wanted to make sure that we were paying very close attention to any sort of change we were making instead of a plan for monthly case review. So this is the process that we implemented. So if a provider was concerned for HIT, they were free to order an EIA. That EIA was negative, it was excluded, and the patient exited the pathway. However, if that EIA was positive, we performed what we call an e-consult. And so this was performed by a hematology physician, and basically consisted of, so electronic consultation consists of no interaction with the patient, it's chart review and documentation. So we reviewed the chart, provided written recommendations, when necessary, also provided verbal communication with the team, not with the patient. And recommendations included things like assessing the likelihood of HIT based on the testing results, anticoagulation management, or if we felt like the case was complex and would benefit from a face-to-face hematology consult, we would recommend it at that time. As a part of our standard pathway, the lab reflex to send an SRA, and then we would provide a final recommendation after that SRA returned via e-consult. Again, our recommendations here could include, was additional evaluation needed? Was there anything different for anticoagulation management? Does this patient need to be seen by hematology, and making sure that the patient, if not seen in the hospital, would be seen by us in hospital discharge. Ultimately, this is, from here, we would say if the HIT was either diagnosed or HIT was excluded. And so we implemented this process in February of 2021. And so this was our first year of data. So from February of 21 to February of 22. So there were 646 EIAs ordered at UAB in that year period of time. Those that were negative had HIT excluded. There were 2 patients where e-consult was actually requested prior to that EIA result, and we did perform those. So there was a total of 101 positive results. 14 of those were already being seen by our hematology consult service, so we did not perform an e-consult. So we performed a total of 89 e-consults and provided initial recommendations. You see the SRA results here, 20 returned positive, 64 returned negative, 5 were inconclusive. We're going to come back to that inconclusive category in just a little bit because it's a really challenging category to deal with. But ultimately, we provided final recommendations in that same 89 patients and ultimately diagnosed HIT in 19 patients and excluded HIT in 82 patients. Just how does this working logistically? The average time from the result to the e-consult response was 76 minutes, which is pretty fast. We tried to do our best to really respond in real time in order to give helpful recommendations to the team. Recommendations a day later are a lot less than those that are within kind of the immediate period of time after the testing result. And so how long does it take a provider to do an e-consult? Do the chart review and do the documentation. Our average time was about 11 minutes. We tried to spend no more than 15 minutes, and sometimes it was less than that. So here are our results. So this is looking at bivalirudin use, and you can see here on the y-axis we have the days of bivalirudin use, and this is days per month. So each month is listed here. And what you can see is before our intervention, so in 2020, our mean days of bivalirudin use per month was around 148 days. And so that means, within that month period of time, how many patient days were we actually giving bival? And you can see here after our implementation, a really nice decline in that average to 92.8 days. Again, supporting this, which we think is really based on our frequent e-consult recommendation that some of these patients that had a positive result really had a low T score, had a low probability of HIT, and therefore did not require bivalirudin. Also by making sure that when testing results came back negative, that the bival was stopped rather than continued. Looking at this data another way, same recommendation, but this is the number of individual patients that were receiving bivalirudin. This is by quarter rather than by month. And so you can see here the average was about 56 patients per quarter, that were receiving bival. And you can see that average dropped to 35 after our intervention. So what about the use of direct oral anticoagulants? You can see here the absolute number of patients and the percentage of those that were receiving warfarin in green or red oral 10A inhibitor, which could be apixaban or rivaroxaban. And so before e-consult, 63% of patients with HIT, which is an absolute number of 12 patients, were discharged on warfarin. This dynamic shifted significantly, where 11 patients were discharged on oral 10A inhibitors, only 2 on warfarin after our e-consult implementation. Again, supporting that we had increased uptake of this recommendation guidelines. And what about length of stay? So before e-consult, this is the length of stay for patients with HIT, so those that were diagnosed with HIT. And this is the length of stay where the mean is listed in the full range. And so before e-consult, the average length of stay was 39 days. And you can see quite a long range here. There are certainly outliers involved. But you can see that we significantly decreased that average to 17 days in the e-consult period, which we think was primarily due to the increased uptake of direct oral anticoagulant use, as well as close follow-up with hematology. So we felt more comfortable sending people out of the hospital for close monitoring of platelet count if they were otherwise stable in order to save hospital days. So if we look back at our cases, we had the 64-year-old female that was admitted with pneumonia. And so if this had been in the setting of our e-consult intervention, how might this have gone differently? So if with her positive EIA result would have triggered an HIT e-consult, we would have calculated her 4T score of 3 and recommended continuation of enoxaparin rather than a switch to bivalirudin. And potentially we could have avoided a GI bleeding event in this patient. Our patient who had a cabbage, who did have true HIT, the way that this could have gone differently is actually with that high OD, we would reinforce the plan of the team that we were highly concerned for HIT in this patient and recommended a transition to a direct oral anticoagulant when the patient was medically stable. And therefore, this patient could have potentially been discharged on hospital day 10 rather than hospital day 16 because they could have been started on Xarelto, which does not require a bridge. We could have seen them closely in follow-up. So our conclusions from this intervention is we do feel that our HIT e-consult service has facilitated some positive outcomes. So we've seen adherence to best practice guidelines, decrease unnecessary use of bivalirudin, increased use of direct oral anticoagulants in acute HIT, and a decrease in length of stay for acute HIT. And we're looking forward to hopefully using this as a proof of concept of how an e-consult mechanism on the inpatient side can really be a helpful avenue for us to provide some degree of hematologic oversight for the care of patients with complex hematologic conditions. And particularly looking at anticoagulation stewardship about particularly anticoagulants like bivalirudin or others that may be increasingly complex to manage. If those can be triggered and reviewed by hematology, that perhaps we may have opportunity to continue to improve outcomes outside of it. So I'll pause there for a second just to see if there's any specific questions before moving on to another component of the topic.
So that's an incredible system. My question would be, is the development of implementation, what was the hardest kind of lump to get over?
Yeah, so I'm going to repeat the question so people on Zoom can hear it. So the question was, in the implementation of this, like what was the hardest hump to get over? I'll tell you, when I started it, I thought that the hardest process was going to be getting people to follow the recommendation. But frankly, I think a lot of teams were quite, HIT is a very scary thing. And so I think they were very happy to have guidance. And I think by involving them early on as stakeholders in the process, that they felt engaged and did participate in the consult process. I think the biggest challenge is just having time in order to do things like this. And I think a lot of people can probably identify with this, is that this really started as kind of a pet project, to be honest, without any sort of devoted time. And that ultimately our hope is that with demonstrating benefit, that our providers will receive time in order to complete this service, which is clearly demonstrating benefit. But oftentimes we as providers have to make that jump with our flexible time in order to prove that benefit. Yeah.
How do you account for the confounding factors and length of stay? Because I'm sure a lot of your patients have multiple problems and multiple things to the length of stay. So how do you for that?
Yeah, so that's a great question. So the question was, how do we account for the confounding factors of the length of stay? And you're exactly right. There are so many things that contribute to the length of stay. So can we say for sure that this was related to the work that we've done? Not necessarily. I think the thing is because it's a small enough population and we know these patients individually, we can see where we basically were able to, if we look at the comparison to warfarin management, these patients would have been in the hospital longer if warfarin had been continued. So we're really deducing that. But you're certainly right. There's still going to be people who are in the hospital for other reasons, no matter if we get them on a direct oral anticoagulant or not. Yeah. Mm-hmm.
How about overutilization and inappropriate utilization of testing?
Yeah, that's
before and after.
Yeah, so the question about inappropriate testing. So that is a wonderful question and one that we haven't yet addressed. So I think there were, and if I remember, there are people in the audience who may remember Dr. Jill Adamski, who was here and used to provide oversight over my understanding was that she would review those tests as they came in. The challenge again is volume, right? There's so many of those available. And to the original question about bandwidth that oftentimes we don't necessarily have, unless we develop a system where we have providers with, compensated time in order to do that, it's just a huge volume in order to take on. I think there's been a lot of work in ways to try and use the EMR to help guide providers in ordering appropriately. So other institutions have built in, requiring calculating a 4T score, using targeted education. So I think there's some ways to get around it without individual provider review. But the challenge is those efforts have not been overly successful because I think, as we all know, EMR calculators are only as helpful as the information you put into them. And a lot of time providers, if they want to order a test, will just find a way around it.
In the first result, first study, did you dig deeper and into the provider and see who are asking for this test and why?
Why?
Can you put a hard stop in impact so that they don't order until the consult is being?
Right. Yeah, so the question is, are there certain groups that order more, or can we put in things like a hard stop? I mean, I think all of those are options. There definitely are services that are ordering more. It tends to be services where HIT is more common, so like cardiovascular surgery. So it's a little, there's definitely, not to discredit the providers who are doing this, it's a really difficult decision to decide if to order a test for HIT or not. So we didn't go too much further into that. I think the challenge with a hard stop is just we always have to be careful of not delaying care. So what, can we provide the consult in a timely manner so that if someone wants to order a test today, that I can review that quickly, and if it's appropriate, still get the test done and not delay care for 24 hours while we wait for a consult to be done. So I think that's the balance of certainly wanting testing to be appropriate, but at the same time, not causing harm by taking away something that might be necessary for a very small group.
And and underutilization is also a problem. And there's a group of researchers from Harvard that reviewed the literature on upper utilization of blood testing. They thought they were going to find overutilization as a bigger problem. They found underutilization. So that's why when Lance Williams was here, they created that alert to order the test when the platelet count fell. And that's when they ordered a lot more tests when they need, because that was the best they could do. And pharmacy was really worried about missing somebody. Right. So it's on both sides, it's very difficult to.
But in the last study, out of 600 something.
600 plus per year.
Only around 100 were positive for test. So that's very obvious. They ordered the test and only around 16% came positive and real. So that's obviously.
No, but the risk, they were afraid they were not ordering when they should have ordered, and they were missing the diagnosis.
So I think it's always a question of appropriateness, right? Because it's the balance of over and under, and how can we get to that balance? And I think many institutions struggle with this. And again, being involved in the community, people who are doing this work, no one's got an easy answer. It's really tough. Yeah.
You know that this patient have a very severe thrombocytopenia. And actually, what is the platelet serotonin count you prefer to stop the anticoagulation? Because the risk of the bleeding is very high. The first one. What is the optimal duration of the anticoagulation the patient should go for after they diagnose as HIT?
Yeah.
And do you prefer use of low-dose steroid in this patient because they already have antibody against factor 4 or no?
So those are great questions about clinical management. So the question first was, oh, now I forgot the first one. Level of thrombocytopenia. So there is no level of thrombocytopenia where I stop anticoagulation in these patients. And that's kind of the strong teaching, is that truly, although they are thrombocytopenic, they are prothrombotic. And so really starting anticoagulation is what helps that platelet count to potentially recover. If there are rare situations where you're experiencing bleeding, you may have to stop briefly, but really our focus is trying to get that platelet count up quickly, which rather than using steroids, there's actually data to support the use of IVIG. And so that's what Ted Workinson, who's a big hematologist up in Canada, who is really the expert in HIT, has been using a lot of IVIG in order kind of to disrupt that antibody binding in order to facilitate more rapid platelet count recovery. But it's always a scary thing for providers, but I don't care what your platelet count is. If you have HIT, I'm coagulating you.
Usually it's not that low. So
There's definitely extreme cases, but usually not. The duration of anticoagulation is actually based on if a clot is present or not. And so that's why having us involved in the, once a patient is diagnosed is often helpful. In patients who have HIT without thrombosis, so they've had evaluation for clots and they don't have it. In general, there's kind of debate about how long to anticoagulate them. Most people say about a month. Some people say just until platelet count recovery. Those who have had a clot, we recommend kind of the standard treatment duration that we use for VTE, which is 3 months. And so that is kind of guideline based at this point. Yeah.
Regarding the SRA, which reference lab we send it to?
We send to Versity. Versity in Wisconsin. Yeah. Which used to be Blood Center of Wisconsin. Yeah. Yeah, it's got a new fancy name now. Yeah. Amazing question. Yeah.
So what is concerning is when there's a medium or high probability of changing cancers, still don't order.
Right.
tests.
Right.
That seems to be more concerning.
Yeah, so the point that, you know, the data that I showed that people with medium to high risk that weren't tested, and I think that's to Dr. Marquez's point, is that because just as much as we're concerned about over testing, there's also the potential that we're missing people.
Do you think because of the availability cognitive bias, because they have seen a lot of these cases, so they order it right away when they have even a low probability, who actually have higher probability go missed because, yes.
Potentially, you know, there's a lot of things that might contribute to that. I think the challenge too is that a 4T score really needs to be applied in an appropriate context. And so sometimes even if you're calculating 4T score out of context, there's a lot of causes of thrombocytopenia. And so even with an intermediate score, I mean, that can often be justified other ways. So it's really hard to look at that data retrospectively and know exactly what was going on with those providers. But I think it just gets to the heart of the problem, is that appropriateness is the issue. And because this process is so complex, it's really hard to make sure that we're doing it consistently across a large health system like ours.
Do you think it might be useful if the providers actually got access to an algorithm like this when because all of them seem to be doing the 40 score, but the decision to take it any further is not there. So
Yeah, so actually they're not calculating the 4T score, which is really the problem. That was us calculating the 4T score in retrospect. So that's a great point. Usually if you look at the documentation, which I've spent a lot of time doing, the 4T score is at least not documented. They may be calculating it and not documenting it. But that is definitely what some institutions have done, is basically required documentation or calculation of a 4T score. So it's in the chart, use that as the decision-making point. But if you look at the literature on that, the reality is that a lot of times it's not accurately calculated. People have clicked just to kind of pass through in order to order the test. So it's hard. There's not an easy answer. Yeah.
Question came through in the chat. What are some of the questions on the 4T scoring algorithm?
So it's 4 T's because it's about 4 T's. So the first is the degree of thrombocytopenia. So how much the platelet count drops. The characteristic drop is greater than 50%, but with a nadir not less than 20. And so you get the most points for that kind of characteristic fall. Or if it's a really, well, we'll go into timing is the second T. So timing is basically when the platelets drop relative to the heparin fall. So if you think about it pathophysiologically, if you get exposed to heparin, it takes about 5 days to form that antibody. And so the characteristic fall is between 5 to 10 days after heparin exposure. Or if you've been recently exposed to heparin, a fall within 1 day. If you have preformed antibodies and then your counts fall. So thrombosis, now I think about it. Thrombocytopenia, timing, thrombosis. So whether or not they have a new clot. The important thing is if this clot developed while the thrombocytopenia was occurring. I don't care if they had a clot beforehand. We got to know what's happening in that period of thrombocytopenia. And the last is not really a T, but it's other causes of thrombocytopenia. And this is the hardest part of the 4T score, where basically a provider has to estimate the likelihood of there being other causes of thrombocytopenia present. Is that definite, possible, or there's no other apparent causes? So those are the 4 T's. It's not easy. It's not easy. And again, there's literature to illustrate basically variation across providers, and that if someone is calculating it more consistently, they're better at doing it. And so it's again kind of an advocating for this e-consult method, where you have providers who are doing this over and over again, because you develop that familiarity of what it looks like and what a true 4T score should be. Okay. Well, I'm going to talk a little bit more about something different but related. So as we were paying attention to HIT in this new way, we had an opportunity to really think about how we might even be able to diagnose HIT in a different way, in a better way. And at the same time, literature came out about a new assay called the P-selectin expression assay, or PEA, which that abbreviation is always, I say to people that think of like a PEA arrest. So I feel like I would have tried to pick a different abbreviation, but the PEA assay. And what this does is, rather than measuring serotonin release, it actually measures P-selectin expression by flow. So this is based on some concepts, basically showing that donor platelets that were incubated with PF4 were basically primed to recognize these pathogenic heparin-induced antibodies. And so basically what they would do is prime the donor platelets with PF4, add labeled anti-P-selectin and anti-glycoprotein 2B antibodies, and then do gated flow cytometry in order to identify the presence. So this assay appears to be technically simpler than SRA. Again, speaking as someone who's not a laboratorian, but pooled platelets are used rather than specific donor platelets. It requires a lot less platelets, 1 million versus 23 million. No radioactivity is required. It currently has a faster turnaround time, and the inventors of this assay ultimately see this as something that may be able to run in-house at any institution. It actually has the ability to potentially identify this small group of patients that have HIT but are SRA negative. And so I'm a little short on time, so I'm going to kind of fly through some of these details just to make sure I show you our data. This is the publication that came out in 2021 that actually compared the PEA to the SRA. And we can focus on this curve here, basically looking, the sensitivity and specificity, and see that the SRA and PEA were tracking quite similarly. You see the AUC listed here that was similar between both the PEA and the SRA. So really demonstrating similar performance. With this in mind, our testing practices at UAB has really evolved. So very much in combination with Dr. Marquez, Dr. Sinyard, with Lauren, the COAG lab, everybody involved. We actually presented this data most recently at the American Society of Hematology meeting. Student Dr. Jackson Hosley, who's here with us in the audience, helped compile this data and was able to present it as an oral presentation at ASH. And so what we basically looked at was in 2018 to 2019, this is what we call the pre-PEA period. We were using SRA consistently, and that was the test that we were using. And what we were really interested in are these people who had inconclusive SRA results, because it's really difficult as a clinician where your gold standard test comes back and basically it doesn't tell you what the answer is. And so you're like, well, what am I supposed to do with this patient? And ultimately it's a clinical decision. Do you treat this patient as HIT or not? With the increasing discussion of the PEA, we kind of started incorporating the PEA at provider discretion around January of 2020. And then ultimately in July of 2020, we reached kind of a standard pathway that PEA was basically used in all patients who had an inconclusive SRA result. And collectively, we're going to refer to this as the PEA period, where we were using the PEA. So what does our algorithm for testing look like in this PEA period? It's basically not too different, right? So our people would order a test, an EIA. If the EIA was positive, that would reflex to the SRA. And you can see here if the SRA was positive or negative. If there was any concern for a false positive or a false negative, the provider would have the opportunity to order a PEA, but automatically, if anyone had an inconclusive SRA result, that would reflex to a PEA. And then ultimately, we tended to use that as the final decision of if a patient had HIT or not. And so this is what we saw comparing our PEA to pre-PEA period. So we saw a similar number of EIAs ordered during those 2 periods of time. You can see it's a lot. So those are both around 2-year periods. A similar rate of positivity in those periods, about 14 to 15%. And you can see here then how many SRAs were ordered in that period. And so we see here how many were positive, how many were negative, and how many had this borderline or inconclusive result. And those percentages were similar at each of these time points. You can see here, so it was a total of 15 in the pre-PEA period and 9 in the PEA period. And so what happened in these kind of intermediate or indeterminate people, you can see here in the pre-PEA period, 7 of the 15 were diagnosed with HIT, whereas only 3 or 33% were diagnosed in the PEA period. Again, these are small absolute numbers, so it's hard to make any sort of definitive conclusions, but maybe suggesting that we were able to exclude HIT more definitively in a couple of cases by using the PEA as compared to the period of time where we didn't have access to that. These are the individual cases, and I won't get into too much detail, but just showing you the 12 cases, and I'd like you to focus on the color differentials here. Where basically yellow is all those inconclusive SRA results. You see we were able to get a definitive PEA result in all but one of those cases. In places where the provider was just unsure about the SRA result, had a clinical question, it supported the diagnosis in 2 cases, and one actually led to discrepancy. This was a complex case that was ultimately determined not to have HIT. You can see here, we can't know for sure if we were right. So not all of these patients were re-exposed to HIT, but all of those that were, there was no recurrence of HIT. So the conclusions that we have from this data was basically that inconclusive SRA results are rare, but they can present a significant diagnostic challenge in medical centers with high testing volumes. And this is something that really has not been discussed a lot in the literature, and I think why it generated a good amount of attention at ASH. Is that this is, maybe in clinical trials, they see this less often, but in our real world practice, we're seeing it quite frequently in a high testing volume. A PEA did demonstrate reliability in HIT diagnostic testing, and the number of patients diagnosed with HIT after inconclusive results appears to maybe have decreased with the use of the PEA. And so further study is really needed to establish an optimal testing algorithm. After some internal discussions, we've actually started using the PEA as the first line testing here at UAB. Given a couple of advantages, one is really turnaround time. So we're able to get results often in 24 hours now. This is still sent to Versity, but they're able to run that test more frequently and more quickly. And we do feel confident in those results. I will say we are getting inconclusive PEA results now, which we were not necessarily seeing before. So this is really an ongoing area of investigation. So that kind of concludes what I had planned to talk about today. We talked about systems-based hematology, an overview of HIT, our HIT e-consult service, and then the working on using the P-select and expression assay here at UAB. I want to acknowledge a lot of people that were involved in this. So within hematology, my physician partner, Dr. Jori was very involved in our HIT e-consult service. Jackson Hosley, our fantastic medical student, has been a great advocate and worked through this data, which is not always easy. This is a really complex topic, particularly I probably couldn't have wrapped my head around it in medical school. Brian Restbrook is one of our residents who's helping me with the illustrated review. He's not here today. Of course, within pathology, we've had amazing partners with Dr. Marquez and Dr. Signard, as well as the full laboratory medicine group, as we've tried to work through this. Our coagulation laboratory, Laura is on my speed dial, and I would not survive without her, as well as Carrie and everybody else in the coag lab. We've had really great partners in all of this, so it's a group effort, and we're excited to continue to think creatively about it at UAB. So I'll stop there. I think we've got about 5 minutes left if there's any questions about the second part of the presentation. Yeah.
I want to go back to the.
Yeah, let's do it.
Dr. Marquez and you, both of you said 40 is politically hard.
Yep.
What is hard about it? Because if it's really hard, why not to put it in an AI module like ChatGPT, and then it will call for you automatically,
So that there's actually been AI work in diagnosis that actually just came out a couple of months ago, and there's people are looking at that. The hardest part is that other causes of thrombocytopenia category, and that's where the variation in score often comes from. Everything else is very objective, right? There's a clot where there's not. There's thrombocytopenia. The drop is hard too. The drop is hard too, but particularly
How slow?
yes, and where you like what counts as a drop. And so there's a lot of, particularly people who aren't experienced with the score, but you could teach a computer to do that. What's hard to teach a computer to do is to look for other causes of thrombocytopenia, right? Is it medications? Is it sepsis? Is it DIC? I mean, some of those things we can gather, but that's what leads to most of the variation. But I think the same question that you're asking, a lot of people in the field are asking as well, is can we have a computer do this for us? To be determined.
It's nice. I appreciate you mentioning Jill Adamski.
Mhm.
Jill Adamski, that some of you remember, she worked here for 3 years. She would review and calculate 14 scores of every test that was ordered. And then at the other score that we can talk about.
Yeah, there are others.
When she left and I tried to do that, I tried for 3 months. I couldn't keep up. It was so much. Plus she had left. I had all the other stuff to do.
Well, and that's the thing is, and truly that's probably the ideal, right? She was very skilled, by doing all of them. She was probably a very skilled calculator and could really assess that risk. But the amount of time to do that is just excessive.
Why the guideline would use something that is very difficult to do?
There's nothing else to use.
Yeah, the thing, I mean, it's difficult, but not that difficult, and it works really well. I mean, a negative predictive value is like in the meta-analysis is like 0.99. Like it's like doesn't get any better than this 4T score when it's used by an appropriate operator. And it's really the best that we have. There's been other scores developed. There's something called the HEP score, and none of them have really performed as well. So plenty of people have tried. And part of it is, well, ultimately, if we have better laboratory assays, then do we ultimately need the 4T score? But the challenge is we're not there from a laboratory perspective. So, it's an imperfect solution to the problem, but it's the best that we have right now.
Yeah, that was great talk, and I know virtually nothing about this topic. It's maybe a very ignorant question.
Yeah.
If you
HT score above 4, what would be the downside of just empirically changing therapy and just not even going through this whole process and just assuming they have it?
That's a great question. So what if, what if the 4T score is high and we just treated everybody like HIT? The problem is the risk that comes with those anticoagulants that are not heparin. So like I said, bivalirudin is what we tend to use here. It's an IV medication. It comes with a higher bleeding risk. Cost is an issue, so it's 10 times more expensive than heparin. And that long-term, this has implications for people. So if you can so once you diagnose HIT, it means you can never receive heparin again, which heparin is really the foundation of how we prevent clots in hospitalized patients. It's how we do cabbages on bypass. So it has big implications, but that's it's a fair question.
Right at 1 o'clock. Everybody join me in thanking Dr. May.
Thank you so much.
GPT.
No, it's nothing to do with that. It's cool stuff.
Mom said, her mom said she.